I'm Melanie Cunningham with NAMI, Kentucky, and we are going to hear today from Dr. Leslie Lundt. Let's talk TD. And we're super excited. We actually had a Tardive Dyskinesia mental health awareness skate-a-thon, and Suzanne came down from Ohio, and it was great. We had prizes, and it was for about 2 hours, and we just wanted to do something fun to bring awareness to Tardive Dyskinesia. And we had a table with information and so forth about TD, and then just mental health as well. So
that's great.
Yeah, so Dr. Leslie Lundt is with Biosciences Neurosciences, and we've partnered with them this year and getting the word out about Tardive Dyskinesia. So without further ado, so that we don't run out of time and people can ask questions and make comments as well, I want to introduce her. And so as we get close to the end, we can put questions in the chat, and we'll go from there. And make sure you have your name, as Baron wants, in there, so that we know if you're not a presenter moving forward or a participant. And we want to hear more about Tardive Dyskinesia. And I'm saying it right, correct?
You are, you got it. You know, the easy way is just to say TD. So, TD. But you got it exactly right. So thank you so much, Melanie. And thanks for bringing up my colleague, Suzanne. She gives her regrets today, but she had a really good reason for not being online.
I wonder where she was.
She's at the Ohio State football game.
Okay, she can't miss that. Yeah, they're a big football state.
She had tickets, and I said, go. I got it. So yeah, so she sends her best. So good morning, everyone. I hope my voice isn't too crackly. I'm on the West Coast, so it's a little early for me this morning. But thank you, and thank you so much for having me today to talk about Tardive Dyskinesia. It is a mouthful to say, but if you break it down, it's not so hard. So the word tardive comes from the French tardif, and we all know tardy, like you're late for school. So tardive just means late. And kinesia means movement, like kinesiology. And whenever you see dys, dys, that's Greek for bad. So a lot of medical words have dys in front of it. So literally it means late, bad movement. And that's exactly what it is. So I'm a psychiatrist. I've practiced, oh my gosh, 35 years now. And my son is a psychiatrist, so it's now our family business. About 6 years ago, I was working in the hospital where I still work, and an old friend of mine called me up and said, gosh, there's this little company in San Diego, and they're working on this awesome drug to treat Tardive Dyskinesia. I think you should talk to them. So first of all, I said, what? A drug for Tardive Dyskinesia? We've never had a treatment in, at that point, 29 years for Tardive Dyskinesia. So that was really interesting. And I wasn't so sure I wanted to change jobs, but very long story short, I was so impressed with the medicine that we have to treat Tardive Dyskinesia. I went to part-time for my hospital job and full-time to work with Neurocrine. And for the last 5.5 years, I've spent a lot of time going around the country teaching people about not only Tardive Dyskinesia, but some of the other movement disorders, problems with muscles that can happen with antipsychotics. So I see many of you were in Dr. Pinto's talk on long-acting injectables, which obviously antipsychotics are life-saving, life-changing medicines, but we have to be aware of some of the problems with them, and so we can treat them. And one of the potential problems as a result of antipsychotics can be Tardive Dyskinesia. So I'm going to go ahead and start with the slides here. So obviously I'm not coming here as your physician. This is an educational presentation only, not intended to give medical advice. Anything I talk to you all about today, be sure and talk to your prescriber about if you want more information customized to your family member's situation. So our plan today is to talk about TD. What does it look like? How do you diagnose it? And then a little bit about treatment. I have to say, similar to what Dr. Pinto was talking about, It's been a challenge to talk to physicians, nurse practitioners about tardive dyskinesia because many people either weren't trained on it at all and didn't get it in school, or they think that tardive dyskinesia is gone, that it's a thing of the past. So one of my favorite papers that was published on this says, forgotten, but not gone. You know, we usually say gone, but not forgotten. This is forgotten, but not gone. We had hoped with the newer antipsychotics like Clozaril and Risperdal and, you know, Abilify, all of those, that this would go away. We had hoped that this was a problem with the old medicines like Haldol and Prolixin, but unfortunately it hasn't gone away. And so many more people are prescribed antipsychotics like Abilify now than they ever have been in the past, that actually the numbers of tardive dyskinesia are increasing instead of decreasing. So anyway, we'll have lots of time to talk about that. I also am thrilled to share some patient videos who these folks have kindly authorized uses of their videos for educational purposes. So a big shout out to them for helping us educate people, because this is something that you can talk about all day long, but until you see it, it doesn't often click. So tardive dyskinesia, as I said, this is a late onset bad movement or abnormal movement, and it's associated with medicines that block dopamine in the brain. And the big ones, of course, are the antipsychotics, and the old ones like Thorazine, Haldol, the new ones like Abilify, Vraylar, but also medicines that are used for gastrointestinal disease. Most common is Reglan. There's another one called Phenergan. So it's not only a dopamine schizophrenia or mood disorder problem, it can be sometimes people with stomach issues as well. So some people that are on these medicines develop tardive dyskinesia. We don't know who's going to get it. That's something we're really intensely researching. Like, how do you know who's going to get it, who's not going to get it? At this point, there's no way to predict. We do have some risk factors that we'll chat about, but there's no test that you can get that tells you whether or not you're going to be getting tardive dyskinesia. Interestingly enough, animals don't get tardive dyskinesia. So you could give your dog all the Haldol in the world and your German Shepherd will never get tardive dyskinesia. I don't understand that at all. Nobody else does either. So this seems to be a purely human process. So as I mentioned, the use of antipsychotics has gone up dramatically in the last several years. And that's primarily because in the old days, back, you know, when I started training, we only used antipsychotics for schizophrenics. And over the years, we've expanded the diseases where antipsychotics can help to bipolar, depression. And so the numbers have just exploded. And as I mentioned, along with that, the amount of tardive dyskinesia has gone up. So we're not really sure how many people have tardive dyskinesia in the United States. Our best guess is 600,000 people. I just came from Atlanta yesterday and I met with one of the world's experts on tardive dyskinesia at Emory. And he said, oh, this is so wrong. He thinks that there's at least 1.5 million people and probably more. So 600,000 is a very conservative estimate. So what does TD look like? Now, the thing about TD that I think is the biggest challenge and the toughest time I have teaching other psychiatrists is that once you've seen one patient with TD, the next one walking in the door could look totally different and still be TD. So we have to kind of expand our mind into what TD can look like. And there are two kind of issues that make it complicated. One is that TD can happen to any muscle in the body. There are 600 muscles in the body. So from the top of your head to the tip of your toes, any one of those muscles or more could get tardive dyskinesia. So the presentation, how TD looks, varies dramatically from person to person. It might be in my eyes, it might be in Melanie's toes, it might be in Jim's fingers, it might be in Kaylin's tongue. You just never know which body part is going to be affected. The most common body parts are in the face, especially the lower part of the face with the mouth, the tongue, the lips, and the jaw. but not necessarily. It can be anywhere. And then there are muscles that we don't think about as being muscles, right? Like your diaphragm that helps with breathing. You can have tardive dyskinesia of your diaphragm, which affects your breathing. Some people get hiccups as a part of their TD, intractable hiccups. Some people have TD in the muscles that control swallowing. So they have trouble swallowing food, or they choke, or they get pneumonia from going down the wrong pipe. Some people have TD that affects the vocal cords and it changes their speech. I've seen one horrible case of this poor man literally could not make sound because his TD was so bad. Fortunately, he had a great response to treatment. So now he can talk. So anyway, TD can be anywhere in the body. Then on top of it, the other kind of confusing thing is the movements can look very different from person to person. So they can be very slow, even kind of stuck, like this. They can be snake-like, slow, writhing movements, or they can be super fast and jerky and twitchy and anywhere in between. So between those 600 muscles and all the variety of movements you can imagine, there's just an infinite amount of how, an infinite variety of how TD can look. So again, thanks to these patients, we're part of our clinical trials and they've agreed to let us use their videos to demonstrate this. So hopefully the technology will work. And you see the lady with the pink blouse and black sweater. Can you see her move, Melanie?
Yes.
Okay,
yes.
great. So look at her face. One of the most common symptoms of tardive dyskinesia is eye blinking, which she's doing with her eyes. So you can see that she's kind of blinking her eyes a little bit more rapidly, very common. And then she's got movements in her lips. I call it kissy face. Looks like she's, almost kissing, or she's got a little kind of sneer to the side. Her lips are puckering. And this is an example I show a lot. Sometimes insurance companies say, oh, well, that's not that bad. We're not going to pay for treatment for this. I mean, big deal. And I say, really? Can you imagine if you're in public and you're kissing people? Like what kind of problems that could cause in your social life or your work life? Like, I'm a psychiatrist. If all of a sudden I start making kissy faces to my patient, they're going to say, whoa, that doctor is really kind of weird. So even mild movements can be very disabling socially. And actually, that's something I want to chat about for a minute. One of the tragedies of tardive dyskinesia is that people finally get their mental health under control and are doing well, and then they have these abnormal movements. And this is like a, flashing billboard that says, something's wrong with me, I have this weird thing going on. And, people that don't understand tardive dyskinesia react very negatively to this. They often think these people are on drugs or depending on where the movement is, they're aggressive or it's just such incredible stigma for tardive dyskinesia. Okay, let's move over to the middle video with our fellow in the yellow shirt. And notice he's also got mouth movements, but his are different than hers, right? So his are more of his jaw. His jaw is moving from side to side. He's also got some blinking issues, but mostly the jaw. And in this particular clip, you don't see the grimacing as much, but he also does really kind of painful faces. And of course, if your jaw is moving from side to side, even when I do it just for a few seconds, it starts to hurt. You get TMJ pain, it can really mess up your teeth. So there are lots of other consequences to these movements. And then let's look at the lady all the way on the right in the gray. Now she's got movement of her tongue. You can see her tongue moving along the inside of her lips like that. She's also got some blinking. Blinking is very common. And we actually have a neurologist name all these things because that's what neurologists do. And this is actually called bonbon sign. So bonbon, old-fashioned word for candy. It's like you're moving a candy around. I think for today's world, we should call it jawbreaker sign or something that people are more familiar with. But you can see her tongue there, how it's just kind of moving around. And the tongue movements can get much worse. You can end up sticking your tongue out. You could be moving it around. So those are kind of tongue movements. And again, the tongue's a muscle, right? So the more you work a muscle, the bigger it gets, right? Arnold Schwarzenegger tongue. So sometimes people with TD in the tongue have these big, old, beefy, juicy tongues from all this constant movement. And then that can cause all kinds of problems with your teeth, with swallowing. They get sleep apnea because they lay down and their big old tongue obstructs their airway and they can't breathe. So there are a lot of physical problems aside from the stigma with tardive dyskinesia. All righty, let's move on and look at some other movements not in the face. So this gentleman in the white shirt all the way to the left, look at, he's got movements in lots of different muscles. So if you notice his fingers, how kind of twitchy they are, we call these piano playing fingers. And it's important to understand it's not a tremor, it's not the shakes. It's much more three-dimensional than that. His are super fast. Then he also has some rocking and jerking in his shoulders and his trunk. Rocking is, again, a very common symptom of tardive dyskinesia. Then lady in the purple, here's a lady that has a couple things going on here. If you notice, she's got excessive blinking like many of these patients, but she also has some cheek puffing. If you look at her cheeks, they're kind of going in and out like that. So again, you can see from patient to patient looks completely different. You wouldn't think this guy's fingers are related to her cheeks puffing. And then all the way on the right, lady in the white blouse, you can see that she's got it in her toes, right? So her toes are like this constantly. Now, one of the only good things about tardive dyskinesia, it does go away when you sleep. So that's the only time they get rest is when they're actually sleeping. But otherwise, every waking minute, her toes are dancing like this. And unfortunately, many providers don't look at our patients' feet without socks on and shoes. So at least once a year, anybody on an antipsychotic should have their feet looked at to make sure that they don't have tardive dyskinesia in the feet. Okay. So how do we look for TD? It's pretty simple, really. Ask questions. Have you noticed your muscles doing anything you don't want them to? Any body parts that kind of have a mind of their own and are moving without you directing them? And then we do just an evaluation, right? We look at patients, which these days is not always easy if they're on a video screen, or worse, if they're just on a telephone appointment and we can't see them at all. So I feel strongly that patients need to be seen in person once in a while, because some of this stuff you just can't do on the phone. So those are the really important things of assessment. Some of the things we ask people to do when we do see them is to open their mouth so we can see if there's anything going on in there, stick out their tongue, put their hands out so we can look for movements, have them walk so we can see if there's any movement affecting their balance or their walking. And then we do something called a distraction technique or an activation technique. So we'll have them do maybe this with their hand or this with their hand. And it doesn't really matter what they're doing with their hand. It matters the rest of the body. So you have them do this, but we're looking everywhere else, because sometimes this movement, when people are really focused on doing this with their hand, their movements come out even more in the rest of their body. So prescribers may be doing that. So the evaluation is not hard, but people need to do it regularly. So I mentioned earlier risk factors. So these are the most common risk factors for developing TD. Again, we don't know who's going to get it, who's not going to get it. But if these problems are on the list of increasing the risk of having tardive dyskinesia. So of course, the big one is the exposure to the medicines, those dopamine blocking drugs, whether they're the antipsychotic or the anti-nausea drugs. So that's the biggest. So what kind of medicine, what kind of dose, how long have they been on it? That's the biggest risk factor. Second biggest risk factor is age. The risk for TD increases with age. The elderly are at significantly higher risk for tardive dyskinesia. Second line here, treatment with anticholinergic medicines. These are medicines like cogentin or artane. And it used to be in the old days, we gave cogentin to everybody to try to prevent movement disorders. And in recent years, we've learned that's not a good strategy. Cogentin has a lot of problems on its own. One of them is it increases your risk of tardive dyskinesia. And actually, if you have tardive dyskinesia, cogentin can make it worse. So we really want providers to look at cogentin. Artane is another common one. And do the patients really need it, or were they just put on it, 10 years ago as a preventive measure? One thing that's important if your patient or loved one is on anticholinergic medicines, not to just stop them abruptly. It's a medicine that needs to be tapered over time. Another risk factor is substance abuse, and that can be anything from cigarettes, tobacco, to alcohol, to stimulants, marijuana. Any drug of abuse can increase the risk of TD. Then if you've had other drug-induced movements, so there's something called akathisia or dystonia or drug-induced Parkinsonism, if they've had any of those things, that also increases your risk of tardive dyskinesia, because those are all problems with dopamine and muscles. For some reason, people with mood disorders, so bipolar or depression, are more vulnerable to TD than schizophrenia. Again, we don't really know why. And postmenopausal women are more at risk than younger women or men to have tardive dyskinesia. But as I mentioned, the most striking risk factors are how long you've been on a dopamine drug, excuse me, and how old you are. These other things are additive. Okay, impact of TD we've talked about already. You can imagine the negative impact that TD can have on a person's life, their daily activities, anything like, if you have finger movements, putting on makeup or tying shoes can be a problem. Posture, falling, speech, all of those things can be affected. As I mentioned, teeth and jaw problems are very common. And then the stigma, the embarrassment that people feel. And I've seen countless patients with tardive dyskinesia whose lives just become narrower and narrower because they're embarrassed to be seen. And even with their family, sometimes it's just extremely uncomfortable. All righty. So, well, I'm talking fast. I guess my caffeine and my tea is working this morning. So approaches to TD treatment, we're not going to spend a whole lot of time on that, but a little bit. So if you look at the timeline, so the first antipsychotic became available, that was thorazine or chlorpromazine in 1952. Hard to imagine. 5 years later, case reports came out of Germany of women with lip smacking, and they linked it with antipsychotic use. The words tardive dyskinesia didn't come out till 1964, and a Danish scientist coined the term tardive dyskinesia. As Dr. Pinto mentioned in the last lecture, Clozaril came out in 1989, and we really had hoped that would put an end to TD, but it didn't. Clozaril is the least likely to cause TD, by the way, another good reason to use Clozaril, but it still can cause TD. And then guidelines have been published in recent years, and the APA, the American Psychiatric Association guidelines, are that all patients who have been on an antipsychotic have an evaluation for TD at least once a year, unless they have higher risk factors like age, substance abuse, then at least twice a year. So one thing we can do is to make sure our loved ones are getting evaluated for TD regularly if they're on an antipsychotic medicine. So this is a little complicated. I don't know how much science we want to get into on a Saturday morning, but I'll give you the brief version. And if you want more information, please let me know in the Q&A, and we can delve deeper into this. But our scientists were brilliant at figuring this out. I can't take any credit for that. Let me see if I can. Looks like this platform. I was looking for my arrow, but I don't think I can do that on this platform. Okay, well, we don't have to have that. So look at the figure all the way on the left where it says increase in number and sensitivity of dopamine receptors. So those orange balls are dopamine, which is one of the chemicals we think is a problem in mental illness and especially in psychotic symptoms. So dopamine is made in the cell there on the top and then stored in these little bubbles. See those bubbles? There's 2.5 bubbles there on the left. And the dopamine gets packaged into these bubbles, and it's kind of like a safe holding place for the dopamine until it's needed. Then when it's needed and the signal comes down the brain, the dopamine gets released into the valley there in between the two cells and gets sucked up by the cell at the bottom where those wavy lines are. So that's how the dopamine system works in the brain. We're not sure why, but people with mental illness sometimes have too much dopamine there, and that can cause the symptoms that Dr. Pinto eloquently talked about in the last session. So we've developed the antipsychotic medicines, where they're those sort of green half circle things, to sit on the dopamine receptors to block the dopamine from getting through all the way to that second cell to try to decrease especially psychotic symptoms. So, and again, they work pretty well, not perfectly, but pretty well. So that's kind of the setup for how antipsychotics work. But the problem is, again, in some patients, we don't know who, those dopamine receptors, those kind of yellow V-like structures on the bottom cell, they get mad that the antipsychotic medicines are blocking them, prohibiting them from doing their job, so they multiply. So you get increased number of dopamine receptors for some people who've been on antipsychotics. So you might have double or triple the number of dopamine receptors. And not only do they multiply in number, but they also get much more sensitive and kind of prickly from dopamine. So you have an increased number of dopamine receptors. They're more sensitive on top of it. And when dopamine hits those sensitive new receptors, the movements can occur. Because dopamine is not only a chemical that helps us with mood and cognition, but also with movements. So we think that's what causes tardive dyskinesia. So our scientists looked at that system and said, well, gosh, what would happen if you just decreased the amount of dopamine that's coming into the system? If you somehow stop those little red balls from getting into those bubbles where they're protected. So they discovered that there's a protein that sits on that bubble in that vesicle, and its job is to kind of usher the dopamine into the bubble so it can be protected. And that protein is called VMAT, stands for vesicular monoamine transporter, if you care, but VMAT. So VMAT's job is to get the dopamine into those little bubbles and protect it until it's needed. Well, our scientists said, well, what would happen if you block that VMAT? If you made the usher much less effective, and he's on a coffee break and not letting the dopamine into the bubbles. So that's what a VMAT inhibitor does. And the ultimate effect of that is less dopamine in the bubbles, less dopamine that then gets out to signal the second cell. So that was the theory, and the hope was that if you had decreased dopamine down at that bottom cell, that these movements would go away. And in fact, it all works. The VMAT2 inhibitor medicines block that protein, decreasing dopamine, and movements in many patients are significantly improved. So that's the setup of how these new drugs work. There are 2 medicines now in the United States that are approved by the FDA to treat tardive dyskinesia. Both are VMAT2 inhibitors. And like I said, they came out about 5.5 years ago. So revolutionized the treatment of tardive dyskinesia, because prior to that, it was incurable. Once you get TD, you have it forever. sorry, we can't do anything about it. But now we actually have treatment. So this was revolutionary. Okay, well, we've talked about a lot of things today. So just to review, so tardive dyskinesia, late bad movement, is a condition caused by dopamine blocking medicines, such as any of the antipsychotics or some GI medicines like Reglan or Phenergan. After you've been on these medicines for a while, sometimes as short as a month, sometimes as long as decades, some people are vulnerable to getting tardive dyskinesia. People most vulnerable are the people that have been on the strongest dopamine blockers for the longest amount of time. And the older you are, the more at risk you are. Other things like women, mood disorders, substance abuse, use of cogentin can increase risk as well. Can affect any of the 600 muscles in the body. It commonly is in the face, but not always. And the important thing out of today that I just want to make sure is that everybody who's either on an antipsychotic or has been on an antipsychotic, you don't even have to be on it currently, it could have been in the past, gets evaluated for tardive dyskinesia at least once a year. Back in my practice, we did it every quarter just so we remembered. But somebody is looking at the patient to assess for movement disorders on a regular basis. It's a lot harder to do when you're not in the room with the person, but it's not impossible. We just have to remember to use our eyes and ears, use family members to help us be our eyes and ears. I've had family members use the phone to try to show me their whole body on a Zoom call. So I make sure to see everything, including the toes. And like I say, it's really hard on just a phone visit. So hopefully providers are seeing people in person at least once in a while. TD can greatly impact patients' quality of life, anywhere from the actual functioning of the muscle to their interactions with their family and their community. And again, fortunately, we now have medicines to treat TD. So even more important that we find it and can help people that are suffering. So that's all the slides that I have. We have lots of time for questions and answers. So Melanie, I will turn it back to you to help us with that part.
Okay, we are ready. And I have a couple myself. So if you have a question, put it in the chat, and I'll also put it in the chat as well. So I guess there's two. So in your research and your study, your practice, what maybe 2 or 3 drugs do you see that there's a higher probability of someone getting TD? And then, we just came out of Dr. Pinto's LAI. So yeah, are there LAIs for tardive dyskinesia?
Oh, gosh, great question. Okay, yeah. So let's start with the antipsychotics. Like I said, those GI medicines, Reglan is the big one, and TD is unfortunately a common side effect of Reglan. But in terms of antipsychotics, the best ones, the least likely to cause TD, are Clozaril and Seroquel. Again, still can happen, but lower on the list. The most likely are medicines like Abilify, and that could be the long-acting one, Abilify Maintaina, or I'm blanking on the other brand name for Abilify, but Abilify, Haldol, those are the ones I see the most causing TD. But again, any antipsychotic can cause it. It depends on the dose and how long you've been on it, and then just the person. The LAIs can cause TD because it's still an antipsychotic. We don't have any long-acting medicine to treat TD yet. Our scientists are ferociously working to try to figure out how to make this a once-monthly injection, but we haven't figured that out yet. It's chemically, it's very hard to make these medicines into long-acting. So we're working on that, but we haven't cracked that puzzle yet. What medicines reduce TD? So there are 2 out that are FDA approved in the United States. One is Ingrezza, the other is Austedo. They're both the VMAT2 inhibitors, and the data is quite good. So I'd encourage you online if you can go to the websites and you can see the studies and all of that. Fortunately, antidepressants, mood stabilizers, the other medicines we use would be extremely unusual to cause TD. Good questions. Everybody's awake out there in Kentucky.
I was going to ask too, does Neurocrine Biosciences have something? Because I know it seemed like this summer I kept seeing a commercial that comes on for Neurocrine. And can you tell us a little bit about what I can't think of the name of it, but the commercial is running in my head. I've seen it. It comes on TV all the time.
Yeah. So our drug is Ingrezza, and we do have commercials out. That's been one of the most fun parts of my job. I get to help make the commercials for whatever reason. And I'm against this, but they have actors be TD patients in the commercials. They don't have real patients, which I think we should have real patients, but I'm outvoted. So my job is to teach the actors how to have tardive dyskinesia that looks real. So being in Hollywood on the TV, on the set to film the commercials was what an interesting experience that was.
Okay. And what is it called again? Ingrezza?
Ingrezza. And again, Ingrezza. And again, there's another one. Another company has called Austedo. So there are two choices. Of course, we think Ingrezza is the best because we developed it.
I guess another question too, just like Dr. Pinto had referred, is there any kickback from like some of the insurance providers? A lot of our NAMI members are on Medicaid, and so they have one of the 7 MCOs. And I just know, being a former state worker, I did CPS and APS for a long time. We would have, our foster and adoptive kiddos. Some of them would be on a certain MCO, wouldn't cover the medicines. And then when open enrollment came the next round, we would get them into a different MCO that would cover. So it almost depends on your provider, but is there a lot of, I guess, declines for people to get some of the TD medicines on their MCOs, or if they have Medicare?
Yeah, obviously it depends on the insurance, and it really varies from plan to plan and from state to state in terms of Medicaid. But amazingly, most plans by far and away cover the medicine, because there's nothing else you can do. I mean, these are the only things that help, and it can be such a disabling condition that the insurance companies, they can't say no because there aren't any other options. And what are you going to do? The TD is not going to go away on its own. So fortunately, insurance barriers aren't horrible. We do have a very generous patient assistance program as well. So for people that don't have coverage, almost always we can find a way to get them the medicine they need. So Brendan, Jim, I see the chat. Sorry, Melanie, I'm stealing your thunder. What are the blood work requirements? Fortunately, you don't have to get any blood work. So no needles involved here. So that's great. It's really very simple. Ingrezza is once a day. And often the starting dose is the effective dose. So there's not a lot of fiddling with doses or anything. So the hardest part with this is making sure that they're accurately diagnosed, right? That somebody's paying attention, and we sure like to catch it early so it doesn't progress into what can be extremely disfiguring. Okay.
Got another question. I'm full of questions this morning. So I know you had the one slide where you were talking about the different things, the different types of movements. And then there was something about the questions about, like, does your TD affect your relationship? So have you seen, like, with people who have TD, like they end up with some sort of extra diagnosis caused by the TD, just like clinical depression or anxiety, because all of a sudden, you're doing the right thing, you're taking your psychotropic meds, and now I have this twitch in my eye, or something else, and some of it you may be embarrassed by it, in public, because you have to get used to it. And then you got to explain it to other people. It's just a lot, it seems like. So are you all seeing, like, with TD patients, like, they, after a year or two, they've got like a new diagnosis of depression or anxiety?
Yeah,
or
that's
like social
really,
stuff.
Yeah, that's really an important issue. So embarrassment is the #1 complaint people have about tardive dyskinesia. And of course, that can lead to all kinds of problems, social isolation, depression, anxiety, and paranoia. I mean, if you're doing funny things with your face and people start staring at you, then you think people are staring at you, but they are staring at you. So that's not really paranoia if people really are staring at you. So it just becomes this vicious circle, right? So again, just another important reason to recognize it and hopefully treat it early.
Okay. Yeah, I was just wondering if there was like studies or, some sort of that, research that said people who have TD, there's 10% of them that now have depression.
So the interesting thing, though, that we haven't chatted about that I think is especially important for family members is, I don't know about your NAMI. I was on the board of our NAMI here in California for many years. And one of the things that was a hot topic among our NAMI was anagnosia. So it's a really hard word to say and even harder to spell, but that is people who have mental illness who aren't aware of it, who just don't accept it, don't admit it, don't see it in themselves. And TD can be that way as well. So sometimes people have, horrific movements and they don't recognize it in themselves. They don't acknowledge it. They say it doesn't bother them, which is really amazing. I mean, I had one example. Let's see, how can I give this without giving any crucial identifying features? But actually, it was a NAMI person, not in Kentucky, in another state, who I got invited to the state awards dinner. And this gentleman received a big award from NAMI for all the great work that he's doing. And he got up on stage and he had horrible TD. I mean, he could hardly talk, he could hardly walk, he had movements in virtually every body part. And this was a few years ago when our medicines were pretty new. I thought, oh my gosh, he must not know that there's treatment for this. So afterwards, I spoke to his wife. I said, gosh, he's got TD. He's got movements everywhere. And boy, they did not want to hear it, did not think anything was wrong with him, didn't see it, didn't feel it, didn't, just shut me down completely. I was like, wow. I mean, this was one of the worst cases I've ever seen. And that anagnosia not only was for the patient, but the family as well. They didn't want to see it. And so I thought, well, gosh, maybe he's got something else that he's had forever and this isn't TD. So I went back, and he's a fairly well-known guy. So I went back and I found old videos on YouTube of him. And of course, he didn't have any of these movements, 10 years ago. So sometimes people don't recognize it and don't want treatment. So the flip side of that as well.
Are there any other questions or comments from the group?
Well, maybe everybody wants to go grab a quick lunch.
Yeah, we've got one more session from 11 to 12, and then we have an hour lunch.
Oh, then you get a break. Good. Good.
Yeah,
well, this has been a pleasure. I hope everybody had a little bit of learning going on today. Like I say, there's lots of information on the web, both for Ingrezza. You can just go to ingrezza.com and there's all kinds of information. We also have a lot of just information about tardive dyskinesia. There's another website called talkabouttd.com. And there's, more and more and more. We're just trying to get the word out so people don't have to suffer any longer than need be with this. So thanks to Kentucky NAMI. NAMI's got a big old place in my heart. So love working with you guys. Keep up the great work.
We're going to have another skate-a-thon next year, probably in the summer, or maybe like when school gets out, because we want really like a lot of kiddos to come as well, so that they are aware. So we might move it up to May, or just right after they get out of school. So,
well, I'll make sure Suzanne invites me. I'd love to come.
Sure, we'll send you. We have some extra shirts, so I'll be sure to send you one.
Fantastic. Well, enjoy the rest of the conference. Thanks again for having me.
Okay, thank you.
Appreciate it.
Yeah. All right, so we ended a little early, guys. I know we have Sylvia Lovely's got her writing class, or her presentation, and then we have two from Steve and Kyle, and they're going to be doing NAMI signature presentation programs, sharing your story with law enforcement and ending the silence. So looking forward to those. So you all have a little bit of a break if you're going to attend those two sessions.